Welcome everyone to today's webinar, Snapshot of the New Landscape, COVID-19 and Substance Use Services. This is the first in a series offered by the National Council for Behavioral Health as part of the Social Workers on the Front Line of the Opioid Epidemic Learning Collaborative. My name is Amanda Baer, and I will serve as the moderator of today's webinar. Before we get started, I'd like to bring to your attention that this webinar is being recorded and the slides and recording will be made available within 48 hours. There will be a brief survey following the webinar for you to provide feedback. Next slide. There are two audio options for today's webinar, phone or computer audio. If you are using your telephone, please make sure to enter your participant ID and mute your computer speakers. Next slide. All attendees are muted today. During the webinar, you can submit questions or comments using the Q&A box located in the navigation bar. Questions for our speaker will be held until the end of the presentation. Next slide. Today's presenter is Tom Hill, Senior Advisor with the National Council for Behavioral Health. Tom is an authority on policy and programming issues related to addiction and recovery. With more than 20 years of experience implementing training and technical assistance initiatives, he is a sought-after thought leader in the recovery field. And now I'd like to turn the presentation over to Tom.
Well, good afternoon. Thank you, Amanda, and welcome everybody. This is a thrill to be able to walk you through this snapshot of what our landscape looks like right now under COVID-19 conditions. We have been navigating this at National Council for the last 6 weeks, and I know on your end you've been doing the same. But on our end, we've been, shuffling a lot of resources, trying to figure out what's what, to decipher that information, get it out to our members, get it out to the field. And there's been a lot of resources that have percolated over the last 6 weeks. And so we wanted to give you an overview of what some of that looks like and how that's playing out in various sectors of the field. So we're not going to go too much in depth on any one thing, but we're going to give you a pretty good overview. So the learning objectives today, we're going to review federal and state policy changes that have been a result of COVID-19. We're going to underscore the susceptibility of COVID to people using substances, people in recovery, and special populations, and then we'll highlight some of the changes in practice and other considerations across service disciplines. So to frame out the dialogue that we're going to be having, one of the things we know that, and we sort of sensed this from the very beginning, that as soon as stay-at-home policies and social distancing and sequestration started happening, we knew there was going to be this sort of collective sense of depression and anxiety, people being sort of isolated a little bit and not being able to go out, not being able to do the normal things that they do. And not knowing how long it's going to last or what's next. And then on top of that, an economic downturn, people losing work capacity, just a sort of general feeling of living on the edge of the unknown in so many ways, and feeling really vulnerable. And we know that when that happens, substance use usually goes up. And relapse can often happen with people that are in recovery. So just something we sort of been watching from the very beginning, and we'll continue to watch. The other thing is that partially the reason why we're all together is really because of the addiction epidemic, sometimes called the opioid epidemic, but we call it the addiction epidemic because it's not just opioids. It's stimulants, it's alcohol, it's marijuana, it's a lot of different substances that are part of this whole addiction epidemic. And then the overdose epidemic, which is a separate but overlapping epidemic. And we knew that there were going to be implications of these epidemics and this pandemic intersecting and possibly and likely crashing. And so it's something that we're watching a lot in terms of the opioid epidemic is not going away. And in fact, it could resurge in a way in regards to the last thing we just talked about in the former bullet. The other piece is because of COVID, there's been a lack of access to EMTs, to emergency departments, to general hospitals regarding people with addiction issues or overdose issues. So that's something that we're also watching. For people who are still using drugs and people in recovery from SUDs, we're more susceptible to COVID at a higher risk for complications due to comorbidities and compromised immune systems. And we'll talk about that also. And then like I said earlier, there's been vast policy, program, and practice changes taking place in treatment, in harm reduction, and recovery services, as well as those in corrections and homeless populations. So we'll discuss all of that. So let's move on to the next slide. Start with the policy changes. One of the things that the National Council does is we do a lot of federal policy, and we've been very, very busy on Capitol Hill, mostly around funding issues that Congress is putting together of large packages of money that go out to the healthcare field. And we have been really instrumental in making sure that they realize that the behavioral healthcare field, mental health and substance use disorders, are part of healthcare, and that money needs to be earmarked specifically for behavioral health agencies and systems because of the various things I talked about earlier, because these things are exacerbated, these issues are exacerbated as a result of COVID-19, and we want to take care of how they look now and how they're going to forecast out in the future. And so we also know that because of the lack of being able to physically see patients and clients, and we'll talk about changes in telehealth, that a lot of our organizations lack capacity in terms of being telehealth ready. And so they need funding infrastructure to be able to support the kinds of changes they need to make. So we've been advocating for the field in the various packages that have come out, and the fourth of which is in the works right now. So the money that's coming from Congress, earmarked for behavioral health, is largely the result of work that we and other advocacy groups in the behavioral health field have done in the last 6 weeks. The other big changes are regulatory activity, and we're going to go into these in more detail, but Center for Medicare and Medicaid Services, their actions on telehealth and policies, the Federal Communications Commission, Telehealth Equipment Fund, the DEA changes to registration and telemedicine requirements, and we'll talk about each of these things. So let's move on. We'll start talking about the FCC changes. There's $200 million available. Applications are accepted on a rolling basis. Eligible providers include community behavioral health organizations, and it funds technology and equipment to bolster telehealth services. So like I said earlier, the capacity and the equipment and the technology that some organizations had and some organizations didn't have this will address the funding for, hopefully, for at least some of that capacity building. Move to the next slide. Told you some of the things that the National Council for Behavioral Health has been doing. One of the things that we've been, really concerned about is the welfare of our members. So we have, members all across the country doing direct mental health and substance use disorder treatment work. And we also have state associations of all these organizations. And so in response to our members' needs and needs in the field, we put together a series of what we call COVID-19 office hours and activities. They're mostly 1-hour sessions. As they have sort of unrolled, we've gotten more organized in how we're sort of looking at doling them out. And so we now have scheduled office hours on Tuesday and Thursday every week from 3 to 4, and a variety of sort of subtopics and sub-audiences. So we have office hours on self-care and compassion, on telehealth, on rural health, on SUD services, children, youth, and families, health equity, and peer support. Trying to hit all the areas that and all the people that are affected by COVID-19 through mental health and substance use disorder services. So they've been really, really successful to the point where now we've actually built a little infrastructure around that. And those are open to anybody. So you can check out the recordings from the past office hours, but you can also register for upcoming office hours. They're open to everybody, and we really welcome your participation. Let's move on. So here's some of the so the stuff I've talked about early, previously to this moment is really behavioral health oriented, both mental health and substance use disorders. And now I'm going to move more into substance use disorder specific policy change. So from the Substance Abuse and Mental Health Services Administration, that's SAMHSA, it's about mid-March, they put out a bulletin allowing states to request blanket exceptions for all stable patients in opioid treatment programs to receive 28 days of take-home methadone doses, and then less stable patients could receive up to 14 days. So this sort of blanket policy of take-home methadone is really very, very responsive to people not having to leave their house every single day to go get their methadone dose, which is the way OTPs generally practice. So this was a big, big change, and a really good change in terms of people not having to travel every single day. However, for anybody who is a new patient, SAMHSA still requires an in-person medical assessment prior to being admitted to an OTP. So this is done for medical reasons, and I've looked into it, and they seem sound. However, it is a barrier to new people wanting to seek treatment, especially under the circumstances where they have to meet physically and be examined by somebody physically. And we'll talk about what some of the issues are in terms of treatment providers meeting people one-on-one in a physical space. You can imagine what they are. So let's move on. The other changes are the DEA relaxed telehealth restrictions. So this was a really, really big thing. In a previous policy webinar, we've talked about telehealth and the barriers to it because of something called the Ryan-Haight Act. And the National Council has been for many, many years trying to get the DEA to relax the initial in-person assessment, saying that it could be done through telehealth, the same as the rest of any kind of treatment provision. So the DEA has relaxed that initial assessment, which is a really great thing. So you can actually, either through telephone or through video conferencing, speak to a psychiatrist and get the medication that you need, which is usually buprenorphine. And so for rural people and also people now that are required to stay at home, it really eases that restriction. So now, ex-waivered prescribers, those are people that have taken the training to be DATA 2000 waivered, meaning that they are capable of prescribing buprenorphine. So that can now be prescribed via video or telephone. So that's a huge, huge change. And providers can use less secure tech platforms. So the restrictions were really, really high before. Now they can use, so you can't use a public facing one. So you can use as a communication vehicle, you could use Facebook Messenger, but you couldn't use Facebook that's the public venue. So there's, they thought through some of these restrictions and trying to lift as many as possible to make access as quick and meaningful as possible. So HIPAA and 42 CFR Part 2, both restrictions around confidentiality, they've been relaxed for telehealth. Now, these are all during this period. The interesting thing is going to be to see which of these are sustainable past COVID-19. And so for some of these, like for the restrictions around telehealth, around the in-person assessment, we're hoping that people will see that it really doesn't really matter, that it is actually better to have that removed or relaxed. And we'll see how that plays out. So the restrictions on Medicare reimbursements for telehealth have been waived, and restrictions on receiving medications have been relaxed. So this means that medications can be delivered by parties other than licensed clinicians, and through indirect means. So you can actually deliver a medication, drop it off at somebody's lockbox outside their house, and so it's a much easier way to receive the medications, set it up through telehealth, and then receive it by having it delivered. So these are all restrictions that have been waived or relaxed during this time. Let's move on. And on a state level, because we do state work also, and we work with states and state associations to do state policy and state legislations where they live and work. And so reimbursement for telephone-based services has been authorized by many state Medicaid offices. That's a great thing. Emergency special enrollment periods for health insurance have been opened in some states so that people that are on private insurance and not Medicaid can get some special enrollment. And then some states have paused housing foreclosures and evictions until further notice. That's not direct, but it's certainly indirect and certainly very important to a lot of people overall, but certainly people that are receiving treatment during this time. Let's move on. So those are some of the policy changes, and you can imagine that they have made things really, and there's been a huge change and shift, both out of necessity, but also, this whole reliance on technology. I always say that, if COVID-19 had happened, if it was COVID-9 or 09, if it happened 10 years ago, we would not have the reliance on telehealth and on technology in general as we do now, which has really been a saving grace in a lot of ways. So we're going to move on to this area where COVID-19 has specific ramifications for people that are using drugs or people in recovery from drugs. And when I say drugs, I mean alcohol and other drugs. So the first is opioid use, because that's what we talk about a lot right now. And the main life-threatening effect of opioid use is slowed down or stopped breathing. And so we know that chronic respiratory disease increases risk for fatal overdoses. And that means slowed down breathing, which decreases oxygen in the blood, which can often lead to cardiac, pulmonary, and brain complications. So diminished lung capacity from COVID-19 could increase the danger for opioid users. And we know that naloxone blocks the effects of opioids and reverses breathing difficulties that are caused by opioids, but it doesn't have an impact on the breathing difficulties caused by COVID-19. So it may arrest the overdose, but the breathing difficulties are going to still be there if somebody is positive or has symptoms from COVID-19. So we're going to move on to the next slide and talk about some other substances. For people who smoke and vape, we know that harms the lungs and that diminishes the ability to respond to infection. For people that are using methamphetamine, methamphetamine constricts blood vessels, which contributes to pulmonary damage and pulmonary hypertension. And alcohol. Excessive consumption can have immune-related health effects such as susceptibility to pneumonia. Alcohol can impair the body's ability to defend against infection, contribute to organ damage associated with alcohol consumption, and impede recovery from tissue injury. And individuals with alcohol use disorder are more likely to develop pneumonia, tuberculosis, RSV infection, and acute respiratory distress syndrome. So all of these substances affect the body physiologically in a very specific way that intersects with COVID-19. So from the very beginning, we have heard that, even people in recovery who may have years of lack of prevention for years and damage to the body from the alcohol or drugs that they took could be susceptible as well. And we also know that alcohol right now, that sales are on the rise, that people are purchasing and obtaining alcohol during this period of sequestration, probably to alleviate stress or to alleviate boredom. Something for us to watch in terms of how people are affected physically, but also how they might be affected mentally or emotionally. And we'll talk a little bit more about that. Let's move on to the next slide. So for people that are using drugs, and these are folks that we've really come into contact a lot, largely because of the opioid epidemic. We know that for people who have no place to stay, they've got no consistent access to hand sanitation and general hygiene, and social distancing is difficult, if not impossible, in shelters and encampments. There are also people that may be housed in unsafe situations. Previously, we've told people not to use alone, and others may need somebody to prepare or inject the drugs for them. Usually, people that are in couples sometimes have those relationships. I just learned of a resource for people, the whole practice about not using alone. There's a website called neverusealone.com, all one word. And it is, you can check in and have and give everybody, you can give the person on the online the information of where you are, that you're going to be using from such and such a time to another time, and they'll check in on you so that you really, if you're virtually not using alone. So this is one of the things that have sort of bubbled up in terms of technology and creative responses to the situation we're in. Users are already at higher risk of other health concerns. So we've talked about some of the things that are directly related to COVID-19, but there's also things that are indirect. Users are at higher risk of arrest and incarceration, and we'll talk about that a little bit more. And then this whole idea of, we talk about the disruption of the supply chain in terms of healthcare, but it's not limited to legal products. So as illicit substances become harder and more expensive to acquire, users will face withdrawal or they'll move on to riskier substances. And so that's not just, supply to heroin or illicit drugs, but also some states have put in requirements to shut down liquor stores as non-essential businesses. And that has effects that people may not think of right off the bat. For somebody who has a chronic alcohol use disorder, not being able to have alcohol or be able to purchase or drink alcohol could have very serious consequences in terms of how people react to the withdrawal. To the next slide. So we all know what the general recommendations for public COVID-19 prevention are. And I'm not going to go through for all of these, but the question that's out there is, how do you follow these recommendations if you do not have a place to stay, or if you're living in group settings or crowded conditions? It's very hard to, like I said earlier, to wash your hands and keep clean if you don't have access to water and soap or cleaning supplies. We know that some living situations like shelters and jails and prisons are not the most sanitary and clean. And we also know that people are living in very crowded conditions under one roof. And this isn't just those situations, but anybody living in group situations. We'll talk about also. So let's move on to the next slide. Here are some of the implications for services that we have been sort of keeping track of. There may be more, but these are sort of the essential things that we've been noticing. So we talked about jails and prisons. And those incarcerated in correctional facilities face greater risk of infection and even death due to close quarters and higher rates of underlying health conditions such as heart disease, cancer, and liver disease. Guidance on how to manage incarcerated populations in a pandemic has been limited. So as a result, there's been a lot of advocacy on mostly state level, some municipal and county, some federal, but a lot of state advocacy around deprioritizing law enforcement effects that focus on drug possession, loitering, prostitution or solicitation, trespassing, or other nonviolent offenses. So the first recommendation has been to divert those kinds of efforts from the beginning and try to keep people out of the jails and prisons to begin with. This is during this time. Again, some of these policies may have longer reaching implications. Suspended admittance of convictions of low-level crimes, release people who are currently detained in order to reduce crowding in detention facilities and coordinate with the existing services to ensure the safety of those who are released. So looking at elderly staff, looking at people who have committed low-level crimes, nonviolent crimes, decarcerating those folks, but also getting them back in the community safely with a plan so that those that are released aren't just sort of out there untethered and without support and services. Improve conditions for those who remain incarcerated and improve conditions for correction staff. So we know that there is a workforce shortage in corrective staff. If correction staff gets sick, there's rarely somebody to replace them. No plans in place for a plan B. So we want to keep people that are working under those conditions to be safe and healthy, and as well as the people that are incarcerated and living under those roofs. Let's move on. So some of the implications, and this is from the American Medical Association, suggests that correctional and justice settings should temporarily waive strict requirements for submitting drug tests, in-person counseling and check-ins and similar requirements, that they should suspend consequences for failure to meet strict reporting, counseling, and testing requirements, including removal from public housing, loss of public benefits, and return to jail or prison. And additional efforts must be made to ensure people receiving medication-assisted treatment in criminal justice settings receive help in transitioning to care after release. So that they, if they're receiving medication in jail or prison when they're released, there's a connection for them to keep on their medication upon reentry. So let's move on to the implications for outpatient treatment. So outpatient, there's been, like I said, a huge shift in the field from in-person to telehealth treatment. This happened almost overnight. And in some ways, this is really great because we have been behind the curve in telehealth. It's something that we have thought about and been initiating slowly for a number of years. And so to have this sort of imperative has made us much more responsible technologically in terms of how available our services are, to the people who need them. So we talked about the organizational capacity earlier, and some of it is infrastructure, some of it's physical infrastructure, But there's also, it's a different kind of practice. It involves different kinds of financing. It involves a workforce development to get people ready and to be able to make that shift, which I think people have made quite easily, but it's still, it's still a shift. And then all the internal policies and procedures that have to happen in terms of all of the above, basically. So it's not a huge heavy lift, but it's a lift nonetheless. And we've been, like I said, very responsive to helping our members sort of make that shift in terms of the office hours, in terms of getting funding for folks, in terms of providing technical assistance to help people to make that shift. There's been some unintended consequences. In certain areas, there's been an increase in workload because the fact that clients could access services through a telephone or video conferencing, people didn't have to make an effort to get to the office or get transportation to the office. They could, use their phone or computer to get there instantly. And so there's been, in many cases, an increase in services or, increase in clients. And then the other piece is that for the people that are using the services or accessing the services, there's been issues where people don't have the technology to do it. So, we think, oh, well, everybody has a computer now and everybody has a smartphone. And that's not always true. Like senior citizen populations don't necessarily have smartphones. Rural populations may have other kinds of barriers in terms of accessing technology. People who are homeless. So part of that has had to, address creative ways to help people get the services they need through technology that's more available to them. So, and we'll talk about that in a couple of slides. So let's move on to residential treatment. So residential treatment, again, is people living under a roof in usually pretty close conditions. So, so one of the things that we have been advocating for, SAMHSA put out recommendations that the field should emphasize inpatient treatment over outpatient treatment. Sorry, the other way around. The field should emphasize outpatient treatment over inpatient treatment unless it was a dire emergency. And that's not exactly the way things work. One of the things is for outpatient is usually not an option for patients who do not have homes or stable living conditions. They often need that stable environment in order to receive treatment and make it successful. As a result, it's essential that doors be kept open and beds made available to patients who need them. One of the things we responded to early on was the Center for Medicaid and Medicare Services put out guidance, COVID guidance for nursing homes, and we took that and took it apart and put it back together and made the necessary shifts and put out a document called COVID-19 Guidance for Behavioral Health Residential Facilities. So that's both for mental health and substance use disorders. And so it's it really goes into all the nuts and bolts of how to make a residential facility as safe as possible during COVID-19. So it gives a lot of very specific recommendations of cleanliness and hygiene and separation and sequestration and ways that people who are living under the same can operate under social distancing and other policies. The problem with a lot of this is that there have been shortages of cleaning supplies and PPE that have to be addressed. So we've been hearing about the shortage of PPE in every sector. Certainly important for first responders, certainly important in hospitals with doctors and nurses and medical practitioners, but equally important in our fields. And so throughout, there has been a shortage of these things that put members of our workforce and members of our communities that are accessing services in a very, very vulnerable position. And then there are telehealth challenges and infrastructure needs across they're the same across all behavioral health centers. So yes, it's great we have telehealth. Yes, it's great we have technology. Now we just have to figure out how to do it right and do it better and do it efficiently and reach the people that we need to reach. So let's move on. Recovery residences are the same kind of situation. Recovery residences are recovery houses, people who are either in outpatient treatment or in early recovery, not in treatment at all. But many houses have been really unsure about whether and how they could admit new residents. So, it's like, how do you screen? How do you can't, until recently you couldn't test anybody. That's been an issue in terms of them getting an influx of new residents. There's been space difficulties in addressing social distancing and sequestration to COVID-exposed residents and social distancing. So in a small residential environment, how do you sequester or separate somebody who is COVID positive? So there's been questions regarding relapse during sequestration. A lot of houses have, policies around relapse where you have to leave the house if you relapse. So if somebody relapses, do you still make them leave the house? Where do you send them? All of those kinds of issues. A lot of recovery residences are supported by the residents who live there, who have jobs, sometimes menial jobs or entry-level jobs, and a lot of those jobs have been lost due to COVID-19. So that's been an issue in terms of their earning power within the house and their ability to add to the house expenses. We worked with NAR to issue those COVID guidelines for residential treatment, which also were applicable to recovery residences, but it's very high level. And so some of them, they could follow an overview, but a lot of the nuts and bolts, the techniques that were involved were a little bit too high level for some of the grassroots houses. Difficulties obtaining cleaning supplies and PPE, again, an endemic issue that we see bubble up again and again and again. And then NAR, the National Alliance for Recovery Residences, has levels 1, 2, 3, and 4 houses. The levels 1 and 2 are more peer-led and grassroots, and 3 and 4 have staff or more closer to residential treatment. So the safety level and PPE for staff in levels 3 and 4 has been an issue. So definitely affecting recovery residences and their vulnerability. Let's move to the next slide. So the implications for recovery programs and peer support workers. When I say recovery programs, that's a pretty broad swath of recovery community centers, collegiate recovery centers that are attached to universities, recovery high schools, peer recovery programs. A lot of them did not really have the infrastructure and capacity to move from in-person to online and telehealth supports. A lot of them have made that shift, but with less resources available, and they've had to sort of really advocate for those resources. Creative ways to engage peers that are accessing the programs. They have, used to being able to do a lot of this work in person, face to face, and having to do much of it on the phone, phone more than video, and how to make those first levels of engagement that happen naturally in a peer relationship, sometimes very difficult over the phone. So they've had to be really creative in how they engage people to the telephone. Difficulties in conducting street outreach. Well, street outreach is pretty much out of the question now. So they're not really doing a lot of actual street outreach due to social distancing. Impossibility of working with peers in jails and prisons and emergency departments. A lot of the overdose work that was happening in emergency departments is not happening now. It's not happening in person. They're doing creative things to be able to engage folks who survive overdose in an emergency department setting, and then connect them with phone supports directly afterwards without the face-to-face. Admitting new members proving difficult, if not possible. So a lot of the drop-in centers, a lot of the collegiate recovery programs got people coming in all the time through the doors and engaging in activities. That's not happening. So their membership is a little bit static right now unless people are being able to access some of the services through phone or video outreach. Staff layoffs, and a lot of these are volunteer driven, but the volunteers can't come in, so there's been an issue there. Some programs have been shutting down, while others are barely hanging on by a thread. And then access to computers and smartphones can be limited. So one of the things that we're finding is that for people who don't have smartphones, and even some who do, they may have limited data plans or limited minutes. And so this idea of having to figure out how to resource the people that are accessing the services to get them more robust data plans or more minutes has been part of an issue that was not addressed earlier when we talked about the FFC communications money coming through. That's not coming through to, as far as I know, to people on the ground who are actually accessing the services. So, I did hear like a creative thing in one peer organization where they had somebody drive to the place. They put a smartphone outside or a tablet outside on the steps. They cleaned it and everything. The person took it in their car in the parking lot, and they were able to communicate that way for a period of time. And then the person dropped the phone or tablet back off on the steps and then went home. And it was just a creative way of lifting a barrier that didn't necessarily have to be there if somebody was thinking on their feet in terms of how to do this in a way when there wasn't any other solution. And then again, like I've said time and time again throughout this past hour, difficulties obtaining the cleaning supplies and PPE. So let's move. So we talked about earlier some of the issues that we're facing people who are using drugs. So we have harm reduction programs, which many of them are like grassroots, volunteer driven, not a lot of staff, not a lot of resources. And so a lot of them are finding that they're having to reduce their programs, their services, or suspending altogether during this time. Some programs are experiencing difficulties in keeping a consistent supply of naloxone and safe injecting supplies. So even if they do have them, like the creative means to distribute them, looking very different than it did in before times. And so one of the things we've been trying to address is that supplies of naloxone not be cut off, and that people be given, multiple doses of naloxone that'll be able to carry them through a longer period of time, as well as more safe injection syringes. Barriers to access during shelter-in-place policies. We talked about that in terms of people who don't have stable living conditions. Workers are experiencing difficulties maintaining social distances while distributing supplies. So, again, a lot of that is street outreach. A lot of it is, setting up vans and tables to distribute them. The hours that they're usually done has been reduced to several times a week, to a couple times a week, or one time a week, and being able to be protective while you're doing that distribution. This is one of those things that's just a reality of life. Is workers they're complaining that they've got difficulties it's difficult to build conversation and relationships with people when your face is covered. So it's like, you can do it through body language, but you can't certainly do a lot of expressive facial work. And so I just thought that was interesting in terms of a barrier that was, keeping people from making that really, really important source of connection and engagement that we know is, one of the tenets of harm reduction. The need for designation of harm reduction as an essential service to prioritize steady flow of supplies and PPE for workers. So this idea of what are essential services and what are not, I think is a really important thing that we'll continue to need to look at, that harm reduction is an essential service. There was a recent communication from the American Medical Association that stated that harm reduction needed to be seen as an essential service. Peer work, which we know is so important in engaging people in terms of recovery, but also treatment, needs to be seen as an essential service. Every facet of our continuum of care really needs to be seen as essential, because they're all integral and they're all really important to the the well-being of the others and the well-being of clients. So just something that we'll keep pressing the dial on in terms of making sure that every sector in our field is seen as essential service. Move on. So this has been a really interesting thing. When I say mutual aid group, most people will think of AA, Alcoholics Anonymous, and Narcotics Anonymous, but there's a range of non-12-step groups also that that people meet physically, they meet regularly, they support one another, they support one another's recovery, they do it in community. A really, really important aspect of our field, although it's not it's a different sector. So as soon as the stay-at-home policies and social distance policies happen, church basements closed down, any sort of public spaces where these groups meet closed down, and almost immediately, I would say within days, but comprehensively within a week, everything had gone to Zoom meetings. And so now it's very easy to connect. We know that isolation is one of the hallmarks of addiction, and we know that connection is one of the hallmarks of recovery. And so for people to be able to connect on Zoom meetings any time of day, regular scheduled mutual support groups now have their same time slot, but not meeting physically. And then people are visiting those meetings from out of town. People who moved away are coming back. So in a way, it's been a real boon to those kinds of meetings. However, people, still sort of mourn the fact that they don't feel physically connected, and they don't feel the energy of being in the room together. And I think maybe that's a good theme for all of this, is that the technology is great and we're really, really grateful for it, and it's really helped us sort of move along in a lot of ways, but we miss being together. Uh, you know, uh, we we miss that sense of connection that we have. And I know that for a lot of you, the things that you've gone through in terms of the vast changes in your school systems and schoolwork and your field placements and everything has changed so much. And it's so great to have, to be able to connect and continue through technological media. But I think we'll all be also really happy when it's over and we can get together for a hug, because it's a great connection, but it's not the same as the connection we feel when we are physically together. So we're lucky to have it, and we will continue to use it in a lot of ways, but we will also be able to go back to some of the old ways, the old school and old fashioned ways we have of being together. So the only other thing about that is that early on in the pandemic, I would say the second or third week, toward the middle to end of March, some of the Zoom issues were coming up in terms of anonymity and sort of interlopers coming in and making the rooms feel unsafe. And so I think there was a lot of corrective action in terms of how to shore up the technology in a way to make it more safe for the people who were there, but still not restrictive to newcomers who needed to join. Because I think one of the things that we'll find is, and we are finding, that people are joining those meetings, joining those groups for the first time through those Zoom meetings. And also that people that are relapsing have a place to go back immediately in terms of being able to check in either with their regularly scheduled group or a new group altogether. So in terms of the availability, that's been really great. Let's move on. So we're going to finish up here and we'll move to the next slide. So we've done so much heavy lifting in the past 6 weeks. It's amazing the amount that can happen in a really short time when certain restrictions are lifted, when people are creative, when we know what our imperative is and move through. And I'm so proud of everyone on this call and everyone in this field in terms of how we have shored up and stepped forward to accept our responsibility and to really harness technology in a way that has really suited us. We have a lot to work out, but we've done a really amazing job in a really short amount of time. So, like I said, there's more to do. We're going to advocate for the continuation of these temporary federal policies. So we've talked about some of this relaxation of restrictions, the lifting of restrictions. They're mostly temporary, but we need to really look at them and say which ones need to stay temporary, which ones need to go back to where they were, and which ones no longer need to apply. And so this is a really great turning point for us in terms of being able to assess that and say, let's remove the baggage wherever we can and lighten our load and move forward and be more responsive to more people in terms of who we serve and how we serve. I said earlier about widening the breadth of essential services. That is really, really so important. And part of that is making the world, making society, making the public, making policymakers, making agency officials understand that behavioral health services are health services, that you cannot separate them out, that everything we do is essential to the well-being of the public. And that with the rise of mental health issues and the rise of substance use and addiction issues during COVID-19, we are more essential than ever. We want to support telehealth infrastructure and reimbursements for peer supports and harm reduction because those folks are at the lower end of the totem pole and need all the resources they can get to continue the really important work. We know through We've known this for a long time, but addiction and overdose epidemics have really taught us that peer supports and harm reduction services are indispensable. And we really need to have them if we want to keep getting people safer and better. And this is true in COVID-19, but it's true overall in general and something that we want to keep sustained. So in the meantime, we really need to figure out how to get resources that'll support that telehealth infrastructure all the way down to the ground. Talked earlier about addressing barriers to phone telehealth. If we want to be really responsive to vulnerable populations, if we want to be responsible to people of lower socioeconomic backgrounds, people who live in rural areas, people who are elderly or senior citizens, we need to make technology work for them, not make them work for technology. And so we really we have an opportunity here to figure that out and how to do it really well. And if technology is indeed portable, we need to figure out how to get it into the hands of the people who may need it the most. About earlier. We know a lot about social determinants of health. We know a lot about health inequities. We know that technology can be a bridge to that or can be a barrier to that. And so we need to really be really mindful in how we figure out how we are going to harness this technology and make it useful to the people who need it the most. So that's part of our responsibility in terms of figuring that out. It's not rocket science. We have the technology available. It's getting better all the time. It's getting more portable all the time. And we need to figure out, and it's getting more inexpensive all the time. So we need to figure out how to get it into everyone's hands and how to teach them how to use it and teach them how to access what we have to provide through all these different sectors in the substance use service field, in mental health, and across the board. So not sure what the next slide is. Some of the resources, like I said, we've been really busy organizing them. They change all the time, and so you could spend a lot of time spinning your wheels trying to find the right resources. I would say in the last couple of weeks, we have at National Council really organized and laid out a platform for our resources in a way that's really conducive, easy to find, and is updated pretty continually. So that's the website for our resource page. There's other resources that I've put together for various sectors. ATOD is the American Association of Treatment for Opioid Addiction. ATOD and some other partners have put together a really great document for all of your questions about operating, staffing, and assessing services for OTPs during COVID-19. So some of the stuff I talked about in the earliest slide, it really gets into the nuts and bolts of how all this gets operationalized. Really, really helpful. COVID-19 guidelines for behavioral health residential facilities, tooting our own horn, but it's a really great document. I've mentioned it earlier. Really, really helpful in terms of everything you need to know. There's a lot of harm reduction resources out there. The best one I found was the National Alliance of State and Territorial AIDS Directors, NASDAD. They've got a really great repository and it's updated all the time. It includes resources from the National Coalition for Harm Reduction, which also has a great repository, but it's embedded in the NASDAD one as well as others. And then the National Alliance to End Homeless, the site for homelessness resources, has all of the HUD and housing things that are necessary in terms of COVID-19 for homeless population. Next slide. There's also, like our office hours series, there's a lot of learning series. Um, the clinical PCSS, the Provider Clinical Support Systems, has had a whole series of discussion and roundtable series, usually on a specific topic. A clinician or two will talk about it briefly, and then there'll be questions and answers. I've been on several. They're really, really good. They've been recorded. I recommend them highly. The ATTC worked with a bunch of partners to do a telehealth learning series to sort of get people, from 101 to 201, up the scale in terms of building skills around doing counseling and other kinds of work in telehealth. And then for the prevention folks, there's CADCA, left the A off there. It's not CADCA, it's CADCA. It's the Community Anti-Drug Coalitions of America, has a weekly learning series through June 17th, and that has mostly COVID-19 specific issues, but some other generic ones as well. And then SAMHSA has another great repository of resources, especially the recovery resources. So all the virtual recovery programs, recovery resources and supports, tips for setting up a virtual recovery meeting. If you have, an in-person one and you can't figure out how to do that, they'll tell you how to do it. And then various hotlines and warm lines that are available for people who need help in the moment. Well, I talked a whole lot and it's been a full hour. And I think we might have some questions that have percolated up through the past hour. So I'm going to look to my tech staff, my support staff, my content staff to see where we are in terms of time and how we deal with that.
Thank you so much, Tom. Thank you for that great presentation. And these are important issues and are continuing to unfold. And you shared a lot with us today. Given the time, we'll ask that anyone who has questions, feel free to email me. My email was in the invitation, and I'll be following up within the next 48 hours with the recording of this webinar and with slides. I would like to highlight the next webinar in the series, which will be Thursday, April 30th at 11:30 a.m. Eastern Time, and that will be extending SBIRT using principles of motivational interviewing. On the final slide, we have the full schedule, which is also listed on the website that is linked in the slide, and we hope you can join us again. I'd like to thank Tom once more for sharing your time and your expertise today. As I noted, the recording of the webinar and slides will be sent out to everyone who registered, and we do ask that you complete the brief survey following the webinar to provide your feedback. Thank you all for joining us, and have a great day.